Hello, my name is Dr. Charles Simone, and today I'm going to discuss early breast cancer to show you that hormonal therapy is as good as or better than chemotherapy for early stage breast cancer. A recent study, the Taylor study, was hyped recently in the media and showed that hormonal treatment alone could be used without chemotherapy for women with early stage breast cancer, hormone receptor positive women who have a low risk of recurrence. This test cost $4,620. Because of intense lobbying, this test was placed into the NCCN Guidelines panel for breast cancer, sponsored by the National Cancer Institute and also by the ECOG Protocol Study Group, all enhancing the credibility of this single test. The total revenue for Genomics Health was $340 million for 2017 and increasing. But this treatment information is not new information at all. What we're going to do now is excerpt from my book that I wrote, The Truth About Breast Cancer, Breast Health, and show you how this information was done a long time ago. In 1992, the medical journal Lancet published two sentinel articles back to back in January. These articles reviewed 133 randomized trials for 75,000 women who had early stage breast cancer and received systemic treatment consisting of hormonal therapy or chemotherapy or immunotherapy. And they found information that was very, very interesting. Hormonal therapy was as good as or better than chemotherapy and immunotherapy. The Lancet convened a study group and an international conference several years later. Remember that those two study papers in 1992. The conference was convened in 1994 after all this information settled in. And what they concluded at that conference, their conclusion was that chemotherapy in the management of breast cancer has a dim future. We know several things. We know that ovarian ablation or tamoxifen or chemotherapy produce similar recurrence rates regardless of the age or whether you are menstruating or not, or whether your estrogen receptor status is positive or negative, or whether your lymph nodes are positive or negative. We know that ovarian ablation is superior to chemotherapy in premenopausal women with estrogen receptor positive cancers. We also know that ovarian ablation plus tamoxifen is superior to chemotherapy. We know that tamoxifen is superior to chemotherapy in node-positive women 50 years old or older. The lifespan is the same. Adjuvant systemic treatment for breast cancer patients with negative nodes. Only about 8% of those patients would benefit from treatment with systemic therapy. And what we do know is that the lifespan has not changed in those patients who do get treated, but the incidence of recurrences during that lifespan is less. And that's an important distinction. So only 8% require treatment or will benefit from treatment. The other 92% won't benefit at all. And this total cost for treating all these people without any good guidelines is about $675 million a year, and there's about a 2% treatment-related death. Now, can adjuvant treatment also be used for breast cancer patients early stage with positive nodes or other high-risk prognostic factors? We know that the lifespan for those receiving chemotherapy or hormonal therapy is the same. That hasn't changed. The disease-free interval, that is, the period of time in which there are no disease events, is longer in women who receive adjuvant systemic treatment. Ovarian ablation is more effective in premenopausal women and perimenopausal women. And ovarian ablation produces the same lifespan and recurrence rates as chemotherapy. Tamoxifen seems to be more effective alone, as effective as chemotherapy and tamoxifen. Combination chemotherapy is better than single agent chemotherapy, but there's no additional benefit. So how do we decide who should receive treatment with systemic treatment? The review of those 133 randomized studies involving those 75,000 women help us greatly. We know that there are prognostic factors that we look at. For instance, the 5-year recurrence rate for having ductal carcinoma in situ is 1%, which means that only 1% of these people who are left not treated at all will have a recurrence. But those studies also show that there's a 25% benefit, 25% insurance policy. So if you factor in that 25% to the 1% of people who would receive benefit from the treatment, you see that the benefit then, if you treat those patients, would be only 0.75%. So it's not worth that at all. But if there's a higher prognostic risk factors, then there will be a benefit. So if the risk of recurrence is, say, 50% or 60%, you decrease that by 25% because that's what systemic treatment will afford you as a benefit, then it is well worth treating that patient. In the table, table 24.2 in our book, lists all the prognostic risk factors for you. So what factors can improve survival in early breast cancer or breast cancer in general? A competent immune system. And this has been shown to increase lifespan over conventional treatment, hormonal therapy, etc. Proper diet and lifestyle, a la our 10-point plan. Antioxidants and other nutrients should be used all the time because they do not interfere with chemotherapy. They enhance the effects of chemotherapy, radiation therapy. They decrease side effects, and at the same time, in 2/3 of the people, will increase lifespan. So what can we conclude? We know that hormonal therapy and chemotherapy give the same survival benefit to patients. Chemotherapy is no more curative than hormonal therapy. So why, after all those studies, after that very important sentence from the editorial staff in 1994 by Lancet, chemotherapy has a dim future in the treatment of breast cancer, why do we still use chemotherapy? Well, patients with cancer have grown up listening to the organized cancer groups, physicians, media, extolling the virtues of chemotherapy. The more often you hear something, the more you believe it, and the more you want it. So if you do have cancer, people gravitate to the issue of chemotherapy. And patients want hope. For instance, over half of a group of patients receiving chemotherapy for metastatic disease, not early stage cancer, but metastatic disease, which is incurable, believe that they would be cured, even though they were told there was no cure with chemotherapy. And even though they were told that the cure rate was different, they discounted what they were told and believed what they wanted. The American oncologist is more likely to advise patients to receive chemotherapy than the European oncologist. Most oncologists advise chemotherapy, believing it would improve survival, and it does not. And patients want their doctors to make their final decisions. Survival for breast cancer has little changed since 1930. Despite all the conventional treatment, chemotherapy, radiation therapy, immunotherapy, etc., all the fancy tests that we have, MRI scans, PET scans, etc. What we have found is when you change your lifestyle, you actually will change the outcome and increase lifespan. Stop feeding the tumor and enhance your immune system following a good 10-point plan that is low-fat diet, low glucose diet, swimming fish from the ocean, poultry, yes, organic poultry, breast meat, anything that grows from the earth except soy products and other phytoestrogens that we see. And you can look up Dr. Simone, phytoestrogens. You'll see a whole list of foods that have estrogen components to them. Aspirin is important as an anti-angiogenic agent. Tamoxifen is an anti-angiogenic agent. They don't allow blood vessels to come in to feed the tumor. The other factors in the 10-point plan are exceedingly important. No smoking, no alcohol, stress modification, exercise. Taken together, these 10 points will do two things: enhance your own immune system, and at the same time, stop promoting the disease. This is a diet-related, hormone-related disease, and that's how we should treat it. Thank you very much. I hope this is helpful. Take care.